something you need to take on board rather than just pushing through protocols all the time.
That's interesting. It's very similar in Guatemala. We've got 3 levels of hospital. We've got the national hospitals, the social security, and then the private hospitals. The national hospitals have got no resources at all. You know, sometimes you get 50 gunshot wounds a night coming in. There's only 2 doctors on shift, and they don't have enough resources. But they see that much trauma. They're so skilled in dealing with it. You know, we can turn up with intraosseous and needle decompressions and hemostatic gauze. They might not have seen the resources, but they understand how to manage trauma, whereas the private hospitals are so expensive. They've got all the equipment, but they very rarely see patients, so the teams aren't very experienced. So it's, yeah. Okay, you talk about ATLS. ATLS is more of a doctor's qualification. At our level, we'd probably do PHTLS. Which courses or experience or employment would you say best prepared you for that role?
I've lost you there, Chris. But I think I got what you said. Yeah, so ATLS, obviously, from the UK point of view, is a doctor's course. It's for hospitals. PHTLS is obviously a good course to have for the trauma. So PHTLS, just general seeing patients, is a big plus, and then adapting and just trying to take in what people are telling you when it's doctors saying this might be good for them in that environment. And being in an ED, you have a lot more resources than you do on the road or if you're on a remote med site. So it's nice to have an ECG, X-ray, fast scan, all these things to hand, because it's make life a lot easier and you haven't got to carry it all, which makes it even easier as well. Yeah. And your resupply is in the shelf. So I think PHTLS is a good standard, and your own experience of being out there. And then if you get thrown into an ATLS scenario, the course is very much doctor focused, but when it actually comes to the scenarios, it's just another patient that you go through your normal protocols of ABC and then treat as you find and then move on.
Yeah. Fantastic. So what would you say would be your key pieces of equipment if you were able to go back and you were invited to set up the ED again? What equipment would you push forward and say was essential for a frontline ED clinic or a frontline emergency department?
I'd definitely say fast scan for me, if I could take one of them with me, a portable one, because you can do so much with it, and it just gives you...
I don't know if that's the Guatemalan side or the Kabul side.
Connection lost.
Yeah. Afghanistan's probably lost power. We'll give him a couple of minutes and see if he'll come back on. He did say it might happen.
We're reconnected. Call ended. But it's the system they've got set up. Have we recorded? It sounds very similar to the Afghan, how they ended up with the military in Afghan. You've got the forward surgical teams, then you've got the roll on, and then...
You've got any questions?
Hello.
Hello.
We're back on. Welcome back. I'll take you out of power cut.
Are you there? No, I was alright. I could hear you talking.
That must have been our end then. Very strange. Oh well.
I can hear you go. He said he might lose power.
What were we talking about?
Equipment. So, if you were to... You're put in the role of team leader again and asked to go and set up a forward ED. What equipment would you push for? What equipment would you try and get on the budget? You mentioned portable ultrasound for fast scans, etc. Anything else?
Definitely a 12-lead. Portable 12-lead monitoring is a must, because it's when you've got everything to hand and you put it all on the patient, you can move around while it's reading blood pressure, SpO2, tidal CO2, everything. It gives you feedback straight away, which is another important piece of equipment. And just consumables. Have enough consumables to make your life a lot easier, so you don't have to rely on an order every week to come in.
Yeah, we both suffered working on remote clinics with patients with chest pain and not had a cardiac monitor, or there's only been one person, or we haven't had the right equipment. It just makes life a little bit more stressful. But I guess it boils down to budget and patient advocates, and you've got to be proactive and you've got to justify the equipment and push it.
I mean, it'd be the same with Chris on the ambulance. What pieces of equipment would he take with him? It's probably the same sort of stuff as well, I would have thought.
Did you have portable vents, or were you using AMBUs, BVMs?
We were using the ones from surgery. So we'd bring them in. If we we're going to ventilate them, then we were going to put them on there, so they'd be going. They come out of operating straight into the ICU, which was sort of like recovery as well. So we had 2 of them, and so they'd just be on them if they were going to go straight onto them. But most of the patients that we're seeing coming through the doors weren't intubated, so because they didn't have the facilities to do anything. We were taking patients from other places where they'd been, like MSF, they'd intubate them and then they couldn't ventilate them, so they'd send them to us, and then we'd have to look after them in the ICU for however long until we could pass them up to Baghdad or into Erbil.
Got you. Did you have any power issues while you were there, or did you have decent backup generators?
No, we had good generators, so that wasn't an issue. But so we had our own supply, so that wasn't a problem at all. They had that all sorted out before the hospital was started up to make sure. Never had no problems with fuel either. So we were always well stocked with that.
What about your oxygen supplies? Was it cylinders or?
Yeah, cylinders, and they were the big sort of EF size cylinders, probably going through 16 every 3 days.
And no issues with logistical resupply?
I think there was, but we never saw it, so we would just order it and say we'd need some more, and it would turn up. But I don't know if it was a problem for the guys that were ordering it and trying to get it through to us, but it always seemed to turn up, and we didn't have an issue. But so we were only allowed to keep patients up to 48 hours, then we had to shift them on to hospitals, either some down to Baghdad or back into Erbil. So we didn't want to get left with patients with long-term injuries. We needed to get them out so we could free up the beds, because we only had 48 beds, 24 male, 24 female, and 3 ICU beds. So we couldn't take people for long. We had to get rid of them as soon as they were well enough or stable enough to move them to the next level. Then we had to.
And presumably by that stage, the Peshmerga had driven ISIS out of Kurdistan, so you didn't have any issues transporting patients back to Erbil.
The problem was we didn't have too many issues, but we had to make sure that there was beds available in Erbil for them to take, because obviously they were coming not just from us, they were coming from 4 other hospitals that were sort of surrounding Mosul, and they were firing them back into Erbil. So it was whether they had enough beds and could they actually take our patients that we were sending them to.
Well, that links in well with the previous podcast when we talked about your medical emergency response plan, and is it current, is it up to date? Things change in a dynamic environment, and you might have tested your plan, it might have worked the previous week, but to get a critical patient to hospital to be turned away, and then they have to go and look for another hospital afterwards, it's you've got to call ahead, really. You've got to have a plan A, B and C for everything.
Yeah, and our coordinator, who's coordinated people being discharged into other people's care or to other hospitals, she probably had than us just dealing with the patients, trying to get these people offloaded to other establishments where they could look after them.
It sounds a very similar, your setup. Do you know how like the military ended up in Afghanistan? You had the forward surgical teams, then you would be like the Role 1 hospital in Kandahar, and then they sent you off elsewhere. It's kind of a very similar setup to what the military in the end did in Afghanistan.
Yeah, and I think that's a tried and tested model, isn't it? You need these people to be the A, B's and C's sorted out straight away and then get them off out of the conflict area. somewhere where you can stabilise and then move them on to the next level to get them sorted out and hopefully rehabilitated. So
yeah,
it worked well. It was hectic at times, but it did work. It's obviously a proven way of doing things, isn't it?
Yeah, it sounds similar to when I worked at the Ibn Sina Combat Support Hospital in Baghdad. Come in, ED department, stabilise up to surgery, and then fly them out to Germany. But you didn't just work there, did you? Did you not work nearer the front line? You occupied and set up an aid station in a derelict building at one stage, didn't you?
Yeah, so after I'd done 2 tours with the hospitals, the guys were coming in from GRM, an American team that had set up, and they had TSPs actually inside Mosul, and they were looking for volunteers. So I flew back to England for a week, and then flew out and joined them for the last days of the push to take Mosul, which was again tough when we were in there. So we set up, as in the pictures you can see, we set up in a butcher's shop. And we had 2 clinics up the road, and you see all the kit hanging up. So that was one of the trauma stabilisation points, and we had one up the road, and that we were about a kilometre from west of the river, which is the final push when they started to clear out. And that was quiet periods and busy periods, and it was literally patient comes in, yes, are they breathing? No. Sort out their airway, sort out their breathing, plug them up with the circulation, and then ship them off to one of the hospitals, wherever it may be, the quickest way out. So we had a fleet of 5 or 6 ambulances parked up all the time where we could put people in and then just say, right, you're off to this one, and then we give them a heads up of who was coming to and with roughly what they had. A couple of times we travelled with patients to the closer hospital run by Americans and Australians and teams in there, and we dropped patients straight to there if we couldn't get them any further, which was still 15-20 minute ride.
So the final push, that was the Iraqi army moving through to clear ISIS out, right?
Yeah, so 1 and 3, the Special Forces, and the 16th were in there. They've been in there since January. Now we're into July, so, and they were looking pretty tired. They were ready to go home, so they were doing the final push, and it was difficult because it's in that urban area where it's all built up, and it makes it a lot harder because they're dug tunnels, so they were disappearing. So it makes it a lot harder to try and clear out with IEDs and everything else that's going on. So tough times. You can only sort of do airstrikes for so long, and then you have to go in with foot soldiers, which is a problem. That's where your casualties end up getting more so.
Yeah, well, it was definitely a long, sustained campaign, wasn't it? And as they closed in on the enemy, as you say, they disappeared in the tunnels. Did that change their tactics? Were you seeing a change from sniper fire to booby traps in the buildings and IED blasts, or was it still a mix?
It was a mix. There wasn't so many, definitely not any more airstrikes because they only had that last kilometre to push in. But everything was booby trapped, or we suspected everything was booby trapped. So children playing in the streets, running around as they do normally, and then they end up tripping something and their shrapnel wounds. We saw a lot of them, and then obviously as people were being released and freed, they would come to us, and then obviously children malnutrition that have been sort of under that sort of regime for 3 years, so you can imagine the malnutrition was horrendous. Yeah,
I can imagine. What about ISIS fighters? Were you required to treat any of those?
In the hospital, when we going back to the field hospitals, we had to treat anybody that they brought in suspected ISIS, and that obviously the locals didn't want to treat them, but we said, look, it's one of the things, they're injured, and we have to treat them. They're a human being at the end of the day.
Yeah.
And what happened to them after that, we've no idea, but we couldn't discriminate. We had to treat everybody no matter what. But it was a tough one for the doctors and the nurses, because obviously they'd had friends and family and that had been under this regime that and they'd lost people. So it's a tough one for them. We had to really sort of tread carefully and try and get them on side, but without upsetting them too much and pushing them into something they didn't want to do.
Yeah, emotions run high in any conflict zone, don't you? You just got to manage them.